Good evening, everyone, and welcome to CornerStones Best of DDW in IBD for the UK, Round 2, our deep dive webinar, presented to you tonight by Drs. Peter Irving and James Lindsay.
Thanks very much indeed, Debbie. Welcome to everyone again, back to CornerStones for something like the 8th or 9th time that I think, 8th or 9th DDW that we've been doing it for. And as we've moved into a more virtual world, we have decided to do some deep dive webinars at the end, really just to try and bring out what we think are either bits of DDW that were worthy of a little bit more discussion, or bits that we didn't get to in the previous presentation. So thank you for joining us tonight for that presentation. I think we know most of the audience have actually been to these webinars before, but I'll very briefly run through the process of how CornerStones Best of DDW is created. Basically, there's a global faculty of inflammatory bowel disease doctors, assisted by a group of fellows also from around the world, representing 12 countries, and we're split up into groups, and then basically all the IBD abstracts that are submitted to DDW are reviewed by the groups and then focused on to try to find the ones that we think are going to be most relevant. At DDW, we then attend these abstracts, be they presentations or posters, and then the fellows work incredibly hard to put together the slides that you're going to see tonight, and then the night that DDW finishes, there's a meeting at which all the chosen abstracts are presented to the faculty, and then the final decision is made of which abstracts make it through to the final slide deck. And then actually in the UK, James and I then cut that down quite a lot further to try to focus on the things that we think are UK relevant, and also cut out some of the abstracts which we think are perhaps less interesting. Here are just some pictures from DDW, from the process we just talked about. And here, most importantly, are the faculty. And some of you may recognize Sam and Aaron, who are the two. I'll just flick over to here to the two UK fellows, Aaron from Barts, Sam from Guy's and St Thomas's. And in case you're interested, this is the global faculty here. And this whole process was originally set up by Marla Dubinsky and David Rubin. And you can see there's a nice big faculty, including not just from the US, but also from Asia Pacific, and of course, James and I from the UK. So the deep dive, we're going to focus on some of the novel drugs that are going to be licensed, either or are licensed or are going to be licensed within the next 12 months. Look at those a little bit more in terms of where we think they might fit in, perhaps looking across the drug classes and seeing where we think drugs may be similar or different. We're going to look a little bit more at combination therapy because we think that's where the world is heading at some point. We'll do a little dive into drug level monitoring and precision dosing because we didn't really address that in the previous webinars, and then some other bits and pieces at the end if we get time. So I'm going to hand over to James now, who's going to start, I think, with JAK inhibitors. Is that right?
Yeah, so I'm just going to start with some of the JAK inhibitor data, and I think some may know, but upadacitinib, the selective JAK1 inhibitor, was approved by the EMA and the MHRA for use just a few days ago, and so ulcerative colitis will be its first gastroenterological indication, although it's already approved for some dermatological and rheumatological indications. And so I'm going to run through some of the slides that were presented on DDW looking at UPA in UC. The trial program included two identical induction studies and then a randomized responder maintenance study. And this first abstract is looking across the two induction studies at the speed of onset of the drug efficacy across a range of relevant patient-reported outcomes, including stool frequency, abdominal pain. Importantly, I think bowel urgency. I think that's a novel endpoint that's going to come out more and more, because I think companies have realized that this is an endpoint that's very important to our patients and rectal bleeding. So this is the nearly 1,000 patients that were treated with UPA 45 milligrams in the induction study versus placebo. And those of you who know the data will know that that dose was highly efficacious at the primary endpoint at the end of induction. But here we see the speed of onset. And what you can see is that you begin to see a significant difference between those treated with upadacitinib 45 milligram once daily and placebo as early as day 1. And I think that's a really striking outcome. You can see maybe day 2 or 3 for abdominal pain, maybe day 2 or 3 for bowel urgency. But I mean, I think that is a really striking endpoint. And those that achieved those early endpoints were more likely to be in clinical remission at the end of the induction period, which was week 8. So early responders do well, which is perhaps not surprising. But what I think is really noteworthy is the speed of response in some patients. Of course, not all patients respond immediately. And what we've seen in several drug trials is that there has been an extended induction period for patients who fail to meet the clinical response criteria at the end of the 8-week induction period. And this is exactly the same in the UPA trials. Obviously, those who responded to either drug or placebo at the end of the first 8 weeks were randomized into the maintenance study, and those who did not achieve the definition of response were allowed to receive an additional 45 milligram once daily in an 8-week open label extension study. And here you can see that of the 125 patients that received an additional 8 weeks, about half had achieved clinical response at the end of that extended 16-week induction period. You can see significantly fewer achieving remission or endoscopic improvement. I think what's quite interesting from this is that in those patients who did achieve the definition of response, who were then randomized into the maintenance arm to receive either 15 or 30, you can see a clear benefit of 30 over 15 in terms of the maintenance endpoints, remission, response, and endoscopic improvement. So I think this is giving us another group of people in whom we need to consider the maintenance dose of 30 versus the maintenance dose of 15 if you need to use an extended induction period. One more in terms of UPA efficacy, and this is looking at extraintestinal manifestations. This is both the induction and then the randomized responders maintenance outcomes in the subset of patients entering the clinical trial program who had an extraintestinal manifestation at baseline. Importantly, they do include anemia here as an extraintestinal manifestation. Some may or may not think that's appropriate, but they do split out the outcomes into anemia alone, arthropathy, and all extraintestinal manifestations. And if we look at the induction studies, you can see perhaps a slight numerical benefit of drug over placebo, but certainly we're not seeing an early signal of benefit. But when you look at the randomized responders in the maintenance arm, what you get a clear impression is that those patients treated with the 30 milligrams, so the higher maintenance dose, were significantly more likely to have resolution of their extraintestinal manifestation, whether that was arthropathy, anemia, or any extraintestinal manifestation, than those either treated with 15 or with placebo. And so I guess what that tells us is that's another group of patients in whom, having had the 45 milligram induction dose, we should be using the higher dose, the 30 milligram maintenance dose.
Should we let's just stop there for a second, because that's slightly interesting to me. What's the dose in rheumatoid? Do you know?
Yeah, they have both the 30 and the 15 milligram, but they don't have the 45 milligram induction dose. So the 45 milligram induction dose is unique to ulcerative colitis.
I'm just thinking, you know, here, are we saying that for some reason someone with extraintestinal manifestations has more difficult disease to treat? Because that, if you go back to your previous abstract, you know, about the people who have difficult disease, then they need high. Yeah, I mean, that's no surprise, and you know, that kind of fits with our understanding of tofacitinib, doesn't it? But here, extraintestinal manifestations, I'm not sure I think of that as a more difficult disease to treat. So that's, you know, that's actually quite useful. It's quite sort of, it's slightly new, maybe, to my mind, anyway.
I guess you have to bear in mind, though, that that anemia effectively is a biomarker for more severe disease. So those who are anemic are probably those with more severe disease, and therefore they may require the higher dose. The arthropathy, no, I agree. The arthropathy, and to some extent, the distinction between 30 and 15 is probably more marked in the arthropathy group. That's the middle graph of each of those panels. So yeah, I can't quite explain that, actually, I have to say.
And I think I might have asked you this on a couple of the webinars before, but you know, one of the things we face in inflammatory bowel disease is patients with spondyloarthropathy, and you know, when we were at medical school, there was no treatment other than physiotherapy for ankylosing spondylitis, was there? Now we have anti-TNF. But I don't think there's any particularly convincing data for ustekinumab or for P19 antibodies with spondyloarthropathy. But I think there is for UPA, and I'm not so sure about the other JAKs.
Certainly for UPA, there are trials in ankylosing spondylitis. And I guess this is the last of the efficacy slides for upadacitinib in ulcerative colitis. And of course now, now we have two nice approved JAK inhibitors. We've got tofacitinib and filgotinib, and obviously upadacitinib is licensed. I believe there's going to be a sort of early access scheme, so I think you'll probably be able to get hold of it at a very reasonable price pretty much from the next few weeks.
As I think you probably can with filgotinib as well, get it at quite a reasonable price at the moment.
Well, filgotinib's less expensive than tofacitinib, but filgotinib's nice approved, so it's reimbursed.
Yeah, true.
As is tofacitinib. So I guess we're going to face this rather challenging debate about which JAK, if you're going to use a JAK inhibitor, which JAK inhibitor do you use? How would you decide between them, Pete?
Yeah, that's a fantastically good question. So I think what we will do is what we always do when a new drug comes out. We'll start using it and we'll start to get a feel for it. You know, if you compare across trials, I think that's difficult. There are certainly, if you look at the upadacitinib data, you can't get away from the fact in ulcerative colitis it looks really good. I mean, there's no question about that.
The magnitude of the delta in ulcerative colitis is impressive.
Right.
I mean, I think from a cost perspective, we're going to see that obviously upadacitinib in an early access scheme is probably going to be the least expensive.
Right.
Then filgotinib, then tofacitinib. From a safety perspective, I don't know that we can make a decision, can we?
Well, no, I think that's absolutely key, isn't it? So I think, having said that the UPA data are really impressive, I'm also really impressed with how tofacitinib has worked over the last several years. And so I think it's a really effective class of drugs. So that's great. Clearly, there have been some concerns about tofacitinib, and we've talked about this before, as have others. It's really important to keep those concerns in perspective. And certainly the FDA, and I'm not sure the EMA have announced what they feel about this yet, but they're kind of putting all these JAK inhibitors in the same bucket, aren't they, in terms of concerns about safety?
Well, I think we don't actually quite know the answer to that yet. So the EMEA has got them under what's called a Section 20, where they are assessing whether they are going to consider all JAK inhibitors for all indications as exactly the same, or whether, for example, a selective JAK inhibitor for ulcerative colitis will have a different safety warning for a non-selective JAK inhibitor in rheumatoid arthritis. And I think we're waiting for that announcement.
But the FDA have
Yes.
bung them all in, and we're
Yes.
waiting for EMA.
Yeah.
Absolutely right. And whether that's right or not, I don't know.
No, I think time will tell on that.
I think, and that's the point. And so when you ask me how am I differentiating between them, a lot of it is actually, I think, going to be down to feel and starting to use it and getting some real world data together and talking to each other. I remember when we first started using tofacitinib, talking to colleagues and just saying, gosh, this is working slightly better than I thought it was going to in a group of people I thought it wasn't going to work in. And I expect that we'll be having the same conversations in UC
with
about Filgo, about TOFA, and about UPA, or whatever we want to shorten them to.
And I like the dose flexibility, I have to say. I quite like being able to escalate the dose. Now, what we probably won't be able to do is escalate upadacitinib back to 45 milligrams after that first 16. I think that will be outside of the license.
Yeah, but we do things outside of license sometimes, don't we? So, but I guess the other really interesting thing about upadacitinib is that there are some data for Crohn's disease.
Absolutely. And here we go. So this is the first report of the effectiveness of a JAK inhibitor in a phase 3 Crohn's trial. And this is the induction data from upadacitinib, again, a placebo-controlled trial, 45 milligram once daily versus placebo. Primary endpoint at 12 weeks. And I think, as I've said before about this, there are two key parts to this trial to understand. Firstly, that the population that were recruited were incredibly treatment naive. Almost everybody had failed an anti-TNF, and 60% of patients had failed at least 2 biologics. And that's a very refractory population. The other thing is that a third of the patients were on steroids at baseline. And unlike pretty much every other induction trial that I can think of, where steroids have to be continued at the same dose throughout the induction period in case by weaning them off you cause a flare, this had a mandatory steroid taper at week 4. So it's got a refractory population with a mandatory steroid taper. And there you can see on the right, like the risankizumab in Crohn's trials, co-primary endpoints using a patient-reported outcome, a sort of stool frequency and abdominal pain score endpoint as a remission, and also endoscopic response, which was a fall in SESCD of at least 50%. And you can see there really impressive deltas over placebo. For that endoscopic response, there almost no placebo response, and upwards of 35% of patients having endoscopic response at week 12. And if you look at the bottom there, you get a little handle on some of the earlier assessments. So you're beginning to see response having significance over placebo by week 2. They haven't shown data as early as the first few days that we've seen in ulcerative colitis, but I think this really is a very exciting new option for patients with Crohn's disease, the first of the JAK inhibitors to show efficacy in Crohn's.
Yeah, I mean, I don't think we can fail to be very happy about the fact that we're likely to get a new mechanism of action, and a mechanism of action that looks great in ulcerative colitis. And this is really encouraging that it's going to be a good MOA in Crohn's disease as well, isn't it? Trial design, since we're there, since you brought it up, mandatory steroid taper and induction, which is unusual in trial design, that we've seen. It normally starts after people have responded, doesn't it? I don't know what it tells us. One could, I think sometimes I feel the message that's coming out is, well, look, it's a mandatory steroid taper. Isn't the drug still doing really well? But of course, the other thing the mandatory steroid taper does is drive down the placebo response, which will make the drug look good.
Yeah,
it almost makes me wonder. Well, no, my guess that as to why this isn't part of standard practice in clinical trials, of course, is to get people through induction, isn't it?
Yeah,
because you want
to roll
people to keep in the trial, and so.
I mean, I think we focused on upadacitinib here. It would be fair to say that filgotinib had some great data coming out at DDW as well. They looked at the extended induction period. They showed that reinduction in patients losing response at the same dose as previously was an effective mechanism. So, you know, I wouldn't want to highlight one over another. We're just highlighting these because it's a sort of suite of studies. And while we do so, let's move on to safety, because I think safety has been a big issue for the JAK inhibitors. And this is the combined ulcerative colitis safety data. So this is the maintenance study of upadacitinib in ulcerative colitis, looking at the incidence of adverse events, severe events, serious infections, and then those two adverse events that we're very attuned to, herpes zoster and adjudicated venous thromboembolic events. And it's looking at patients across different disease indications. Don't forget that it's only UPA in which the induction dose is 45, but you can see that you have both 15 and 30 for UPA in the other indications. And in some of these, interestingly, you have in the bottom two, you have a comparator with adalimumab. And what you can see, I think, as you go across is that certainly in terms of serious events or serious infections, actually the drug does, if anything, a little better than placebo. But when you come to the two that we're familiar with, zoster and adjudicated VTE, there is a slight increase with UPA versus placebo, as we have seen with tofacitinib. So, I mean, I think it's we need to bear in mind, I think you touched on this before, that certainly for things like VTE, I suspect the biggest risk for our patients is untreated active disease and not the drugs we use to treat the disease.
Yeah, and I strongly believe that for for tofacitinib, that probably people are being undertreated rather than because people are avoiding the drug. And my concern is that this will happen with JAK inhibition overall. Having said that, JAK inhibitors are, it's a funny word, but they're strong drugs, aren't they? And, you see that they have an immunosuppressive effect. You see this zoster signal, and most of the drugs we use, not all, but most of the drugs we use do have a bit of a zoster signal. Right, I think even TNF has a slight zoster signal as well. Certainly azathioprine. So if you were to put, and this is a slightly unfair question, I might get a bit more unfair in a minute. If you were to put JAK inhibitors on a scale of sort of where they sit with the drugs that that we deal with at the moment, so I guess, and you can disagree with my scale if you want. I guess at one end you've got sort of you've got maybe Vedo and maybe ustekinumab and things like that.
P19s.
Yeah, P19s probably fit in there as well. In the middle, maybe you've got a bit of anti-TNF, and at the top end you've got steroids, azathioprine, somewhere in that.
JAK's probably a bit below that and a bit above anti-TNF.
Yeah, and that's my field too. And I'm going to ask you an even more controversial question now.
You answer that question, anyway, but carry on. Yeah.
And that is, so we have drugs here that have a herpes virus signal. Yeah?
Yeah.
Okay. The other drug we have that has a herpes virus signal is azathioprine.
Yeah.
You see where I'm going here? No? So one of the concerns about azathioprine is because it allows reactivation of EBV.
Will we see a lymphoma signal?
Right.
Well, I obviously don't know the answer to that, but I think that is a concern. We don't check EBV status before starting a JAK inhibitor. Maybe we should. That's a slightly different point, actually. There are two different risks of.
I've extrapolated all the way. I've gone a long way.
I think we just need to wait and see. It took a long time for us to realise that anti-TNFs have a lymphoma signal. Needed studies of 200,000 people to show that. So I think we're a way off. I think the key message that comes out from a safety perspective of JAKs, all of the JAKs, but I suspect also the other small molecules, is that unlike biologics, where the risk is not exposure related, it's not dose dependent, With small molecules, the risk is, and we just need to be aware of that.
Indeed. Okay, so JAK inhibition. I think it was worth spending some time on that because it's something that that is becoming a bigger part of our practice, and this is another class of drugs that's going to become a bigger part of our practice. We are going to concentrate a tiny bit on etrasimod here. We're not going to concentrate on it for very long, but of course, etrasimod is not the only S1p receptor modulator out there. Ozanimod is out there. It is licensed for the treatment of ulcerative colitis, and soon we hope to hear whether it will have received its NICE approval or not. It's going through the NICE process, and I think an outcome is expected very soon there. This is, of course, completely different to any other drug that we've played with before. It's a small molecule, and the mechanism of action probably relates to egress of lymphocytes from lymph nodes. We don't really know, but it's kind of sort of a trafficking type drug of some sort or another. It probably doesn't matter that much that we don't know exactly how it works. It's whether it works or not that's important, and that's why it was very interesting to see some phase 3 data of etrasimod, which is a subtly different S1p receptor modulator to ozanimod, but we won't go into that. And two sets of data were presented here. Really, the Elevate 52. Elevate UC 52 and Elevate UC 12 studies. Just look at the top of the slide here, and you'll see that Elevate UC 52 was a treat-through study. It was a 12-week induction study, randomized 2-to-1 versus placebo, followed by a 40-week treatment period. Patients stayed on whatever drug they were on to start with, as long as they were doing okay. If you got beyond week 12 induction and you weren't doing okay, you could then drop out to the open label extension that you see at the bottom there. And the co-primary endpoints of Elevate 52 was remission at week 12 and week 52, usual secondary endpoints. Note on the bottom half of the slide is Elevate UC 12, which is the second induction study, and those of you who are involved in trials will know that often the FDA mandate 2 induction studies to show that a trial is effective. And in fact, this schematic here actually shows the timeline as well. So Elevate UC 12 was a study that actually started quite a long time after Elevate UC 52. Again, clinical remission at week 12 was the outcome, and there were the usual secondary endpoints. So let's have a look at the results here. Go to the right-hand side of the slide and you see Elevate UC 52. The top half of that looks at clinical remission, the primary endpoint at weeks 12 and week 52, and pretty good delta there, I'd say, wouldn't you? 20% at week 12, 25% at week 52. Let's not forget this is a treat-through study. It's different to re-randomization of responders. So everyone in a sort of the maintenance part of a re-randomization of responders study will have responded to drug. All those people who don't respond drop out, and they don't in this trial design. It does mean, of course, you capture a few more potentially. It doesn't look like you actually capture that many more actually when you look at these data, but that's true. And then if you go down to the secondary endpoints at the bottom, as ever, when you see endpoints coinciding across trials, to my mind, that's always very reassuring. So endoscopic improvement, symptomatic remission, mucosal healing, which will be here a combination of an endoscopic and a histologic endpoint, all showing benefit over placebo. Now pop back to the left-hand side of the slide, you see Elevate UC 12. This was the second induction study, started after the first one. And for reasons which one can hypothesize about, which aren't necessarily entirely clear, it's performed slightly less well here. The delta is less impressive. It did meet its primary endpoint. Some of the secondary endpoints didn't quite meet it, like mucosal healing, but overall it did. We've talked a little bit about why that might be. Maybe let's not go into that now. Let's instead talk about S1p receptor modulators. I mean, encouraging results. Nice to see that we are likely to have 2 S1p receptor modulators. We don't necessarily understand how they work, but again, where do you see these fitting in, James?
Well, I mean, I think initially the concept is that they might be a sort of pre-biologic drug, like an alternative to azathioprine, and that was predicated on the fact that they showed good efficacy in this sort of either bio-naive or population, but also safety. And it was hypothesized that they may, like vedolizumab, have a very favorable safety profile. And to some extent they do. I think we're going to come on to that in a moment. But I guess, I mean, I certainly don't have any information that allows me to differentiate between the S1p modulators. I mean, I think the data for both are great. We've presented the ozanimod phase 3 trial, True North, several times before, and the data is excellent. For me, I haven't seen too much in the way of different doses being tried, so I don't have a feeling for whether there's a dose response. But of course, there's only going to be one licensed dose, so maybe that doesn't matter. I think the safety is key here, and I think that will be something that we need to explore with time.
Let's talk a little bit about safety. And I think, you know, ozanimod, as we've said, is now licensed. We hope that it's going to be NICE approved fairly soon, and it will be excellent if that is the case. There's been a little bit of noise about ozanimod and how we're going to start it, and in particular the screening that's necessary, and that relates to a couple of things, including bradycardia. So let's try and get that in context. And here we see some of the cardiovascular data, safety data from the True North program, and also from some of the MS programs. And of course, bradycardia is a recognized side effect of S1p receptor modulation, including ozanimod. But if you look at the mean change in heart rate actually seen, it was about 1 beat per minute. The question is, how relevant is this? Well, the answer, I think, when it comes down to it, is that we're going to have to do ECGs on people. We probably won't be using it in people who've got heart block. Otherwise, I think it's probably not going to have a massive effect. And I think one of the things that I think we do need to do here is to learn from the neurologists. So neurologists in the United States, and in fact in Scotland, have been able to use ozanimod. And I've been in the odd meeting where we've had some input from neurologists, and I think we need their feel for how easy this drug is to use in reality. And I get the feeling it's actually probably not that difficult. Certainly the the messages that I've had from those people are, in fact, it's all fairly straightforward. It looks like that we've got a question here, so we're just going to pop back. Loads of questions. Oh, there's quite a lot of questions here. Do you want to just?
You better not. I can't work out how that.
You can't work out how it works, James. No. Technology. He's not very good at this, you know. Right. So this is a question going back to what we said about extraintestinal manifestations and inflammatory burden. Why might they need more drugs? Higher doses. And its question is, do they have a higher inflammatory burden? Well, that's possible, I guess.
I think actually, I think in general, the inflammatory arthropathies are associated with inflammatory burden, so that would be true. Obviously, some extraintestinal manifestations are not, so primary sclerosing cholangitis, for example, ankylosing spondylitis, pyoderma gangrenosum, they're not associated with an escalated with a higher inflammatory burden. But I think we don't know the answer to that.
No. Okay. Just looking at some more of these questions here. So one question relates to, do you think we should use a JAK1 inhibitor over a non-selective JAK inhibitor for UC?
I honestly don't think we have enough data to be able to make that distinction at the moment. I think the issue with JAK inhibitors is all about dose and safety, and I am not sure we have data that will separate them on safety yet. So I don't think we have the ability to be able to make that distinction yet.
Really good question from Melissa Smith here. What about people who've failed to respond to one JAK inhibitor and then using a more selective one or a different one?
Again, I mean, there's absolutely no data to let us know the answer to that. Patients of prior tofacitinib were excluded from both the filgotinib and the upadacitinib, so I absolutely don't know. So
would you try it?
Honestly, not if I had other choices. I mean, I think the only reason that in my mind I think you might get a benefit would be the dose issue. I suspect upadacitinib is slightly better dose than tofacitinib, so you might get just as much effect as using 10 milligrams TDS of tofacitinib. Which
is probably limited by side effects.
Side effects and cost.
Yeah, okay, I wasn't thinking cost. Melissa's asked us to say which one we're going to use first. She's going to push us.
Oh, in JAK inhibitors?
Yeah.
Well, I think it'll be cost. Cost will have a really important role. So if and when we get upadacitinib in an early access scheme, I suspect we'll use that because I think it will be significantly cheaper than all the others. But yeah.
A question about comparing data across tofacitinib and filgotinib. I just don't think we can we? You know, I think trials are notoriously fragile when it comes to comparing data. If you want to look at the network meta-analysis, it's quite clear.
Well, the network meta-analysis show that upadacitinib is better than all the other
in induction.
But there may be trial-related reasons why that is, and so one has to be a tiny bit cautious.
Or in fact, quite cautious.
Quite cautious.
Yeah. And then a question: if a patient with a history of herpes zoster in the past, would you prescribe a JAK inhibitor?
Yes, I wouldn't have a problem. I mean, you know, the vast majority of us are going to have latent zoster in us. I think the key thing, and something we're not doing in the UK, which across Europe and the US is very widespread, is using the Shingrix vaccine, and that's historically because we haven't had that much access to it. And our German colleagues, for example, would be vaccinating all patients prior to using a JAK inhibitor. And certainly, of course, that reduces the risk of zoster. It doesn't eliminate it, but it reduces the risk.
Okay, biologics, James.
Yeah, so I think the key issue with biologics is the P19s, and we're going to see a series of studies in P19s, I think in both UC and Crohn's, but guselkumab is one of the P19s, which is just targets the P19 subunit, so therefore is specific to IL-23. And this is the phase 3 trial in ulcerative colitis. Primary endpoint was response, and you can see there 2 doses and a combined of the 2 doses versus placebo on the left-hand side with a really lovely response signal. Don't forget that we're comparing it to other assets that have used remission as the endpoint. So when we look at week 12 remission, we still see a strong positive signal, but the magnitude of that is slightly lower. And then, like many of the newer drugs, we're seeing both histological and endoscopic endpoints as being important. And you can again see, as Pete said, you can see across here the fact that there seems to be a good response across a range of endpoints, suggesting very much that the P19 class will be effective in ulcerative colitis. There is some data in Crohn's disease. This is the maintenance data in Crohn's disease. Again, it's not the world's best put together slide, but it's showing that a strong signal for remission in randomized responders to guselkumab in Crohn's disease. So, and we've seen risankizumab as an effective P19. Before the question gets answered, I have no way of distinguishing between the different P19s in my mind. I don't know enough about their dosing structure in terms of the pharmacodynamics of that dosing structure to be able to classify. But we're seeing a cross-class signal of benefit, and actually, to be fair, not that we're showing it too much here, a cross-class signal that there is not a concerning profile from a safety perspective.
Yeah, I mean, that's very reassuring in itself, isn't it? I guess the other thing that the question that really comes out of this is, what's the benefit of P19 inhibition over P40 inhibition? And again, I think the answer to that at the moment is we don't know. It's quite clear in psoriasis, isn't it?
Yeah, very clear in psoriasis. I mean, the sequence trial, which is a trial comparing risankizumab to ustekinumab, has just finished recruiting. We've had some patients in it. It's far too early to say whether there's an obvious benefit of risankizumab over ustekinumab. Fair to say that the gazelkamab trials, which included adalimumab as a included ustekinumab as a comparator, although not powered to show a significant difference between gazelkamab and ustekinumab, didn't seem to show much of a signal, being honest, but it wasn't powered, and I think, you know, we need to be a little bit cautious about over-interpreting that.
And the reality is here, again, it's going to come down to cost, isn't it? Because ustekinumab, at some point in the not too distant future, is likely to drop in price in the way that the anti-TNFs have.
Yeah, absolutely. And of course, you know, I can't see a situation in which you would not try ustekinumab biosimilar before a full price P19.
No, well, unless sequence showed a massive delta there.
Yeah.
Which I don't think it's going to show a massive delta.
We don't know.
We'll see. It'd be interesting to see. But no, it's very interesting. It will come back to cheaper drugs later on and how that might be useful as we go forward. But let's just keep on P19s because, of course, you know, we've talked about risankizumab being available in the not too distant future for Crohn's disease. Mirikizumab is the first P19 that's going to be available for ulcerative colitis, at least we hope it is. So this is data from Lucent-1, the induction study. In fact, this was actually presented not only at DDW, but also at ECHO earlier in the year. And again, let's not go into this in too much detail other than to acknowledge that in patients with moderate to severe ulcerative colitis, mirikizumab is superior to placebo. Again, reasonable delta there, both in biologic naive and in biologic failed, although you'll note it didn't quite hit that endpoint in the biologic failed patients. But clearly, it will be great to have a P19. And of course, we were also presented with the maintenance data of mirikizumab at DDW. These were new data, so re-randomization of responders study here, people from Lucent-1 who responded to mirikizumab were then re-randomized 2-to-1 to receive either 4 weekly injections of 200 milligrams of mirikizumab subcutaneously or placebo. And if you pop over to the right-hand side of the slide here, you will see remission at week 52, which of course is 40 weeks of maintenance. Again, you know, nice, impressive deltas here, and almost all of them off corticosteroids. And of course, when you look at histologic and endoscopic endpoints, we're seeing very similar things. So yet another class that's going to become available in ulcerative colitis. And you know, I think one of the things I see when I look at these drugs as they come out is excellent, another new class. Is there one that is a true blockbuster that is really going to change what we do? Or are we going to have to do something else to do better than we're doing already?
So I don't think we have seen a true blockbuster as a single agent in all comers. I think the two things that we could do to improve the situation would either be to develop some science that lets us predict response to individual agents. So rather than treat the whole population, you pre-select those more likely to respond. I think that would be one way. And the other, obviously, is combining drugs, which we're going to come on to in a moment. Had a very interesting conversation with our commissioners today about the fact that we've been quite blessed to some extent in the world of inflammatory bowel disease, in that there have not been a limit imposed on the number of agents that can be tried, as there is, for example, in some of the rheumatologic indications, where, you know, patients are allowed to go through 4 or 5 different drug classes as part of the commission process before they fall out of the commission process and have to go for extra commissioned, you know, exceptional circumstance type stuff. We've not been there because we've not had that many agents, but of course we are just adding agent after agent after agent, and it's not impossible that we will soon face a restriction in the number of classes we can use. And I think that as a community is something we're going to have to consider.
It's not an unreasonable question. If you think, at least with biologics, you do get this law of diminishing returns, don't you, as you cycle through.
Yeah.
And I'm just going to ask you another question there. So, you know, the whole biomarker of response thing, okay, many people, including some very big and very rich pharma companies, have invested a lot of money and time into this. And it's starting to feel to me a little bit like genetics. Apologies to the geneticists out there, that it's really interesting and we might be seeing some small signals and it might take us somewhere. I don't think we're going to get a biomarker that suddenly says, Miles, I apologize, and I really hope I'm wrong in that profile, which is slightly different, but still, that Miles's profile trial is wrong, but is positive. But do you really think we're going to find this? Why haven't we found it already?
I think that the difficulty is that the biggest predictor of poor response is disease severity. And disease severity has an impact on many of the other factors that you might look at, like the microbiome, like a whole range of epigenetics. So I suspect we are slightly trying to delineate a small predictor when there's an enormous predictor that we know, which is the worse you are, the more sick you are, the less well you do.
So I think stop ploughing money into that,
and more into the next
and more into combination therapy, because I think that's where we're going.
Well, so there have been very few combination trials in inflammatory bowel disease. Of course, lots of people say, well, there have been loads, because of course we've had trials of combining biologics with conventional treatments, be it steroids, be it azathioprine, be it methotrexate, for a long time. And we sort of tend to know that combinations do better than single agents. But in terms of combining advanced therapies, I guess the advantage might be that by combining 2 quite targeted treatments, you might be able to deliver a higher efficacy with an acceptable safety profile, whereas the combinations of drugs, including broadly acting conventional immune suppressants, are associated with an increased risk of side effects. So we are beginning to see some combination advanced therapy trials coming forward. There were 2 presented at DDW. Here's one of them. It's called Vega, and it was looking to see whether an anti-TNF versus an anti-P19 versus both anti-TNF and P19, what the impact was on patients with treatment refractory ulcerative colitis. Now, there were, to my mind, a couple of disadvantages of this trial. I think the lack of a placebo arm makes it very difficult to anchor the magnitude of any benefit that you see. The drugs chosen were golimumab at standard dose, guselkumab at standard dose, and obviously the combination of both at standard dose. And you can see this is just the induction data. That's all we have so far. Patients on golimumab and guselkumab did slightly less well than patients on the combination. Not really a strong signal of a greater efficacy for either the anti-TNF monotherapy or the anti-P19 monotherapy, but definitely a stronger signal for the combination, both in terms of remission using either the traditional or the modified Mayo. As I say, I think I think it's a shame there wasn't a placebo arm, because it's very difficult when you've got mixed patient populations to be able to correlate a non-placebo controlled outcome in terms of what that actually means compared to other trials that we have seen. Perhaps the most, or not the most, an important aspect of the trial was the safety profile, and what we see is that there was absolutely no signal that combination therapy was associated with an increased risk of side effects. Although, take it, of course, this was just a 12-week induction trial, and it will be the maintenance data that's more interesting.
Yeah, I'm less worried by the lack of placebo here. I kind of think of this as Sonic Mark II, and of course there wasn't a placebo arm there. It's just, the question is, are you better on 2 than 1? I guess I'm slightly disappointed by the results,
but it's benefit. If you look at Sonic azathioprine monotherapy versus combo therapy, that was a clear
big. Although it was at week 26, not at week 12.
So maybe we need to wait and see the maintenance data.
Right, but I would totally agree with you that safety is an incredibly important outcome there, which is why I was also interested to see this study, which is the other big combo trial that was presented, Explorer. And here I was disappointed there wasn't a placebo arm, because it was just one arm. And so it really doesn't tell us, in some ways, it doesn't tell us very much at all. And in fact, it was a group of relatively, they weren't too bad, were they? They were moderate to severe Crohn's, but they were biologic naive, diagnosed in the last 2 years. So not what you'd call a particularly refractory group of patients.
They had to have a marker of poor prognosis.
Yeah, but what does that mean? Wasn't it the Louis type thing?
Yeah, it wasn't a particularly strong marker.
Yeah. So not terrible. But look at their induction treatment. They get a combination of vedolizumab, adalimumab, methotrexate, and in fact, about 30% of them were also on steroids at the same time. So, 4 drugs in 30% of the patients, 3 drugs in the rest, and then the primary outcome here was remission at week 26, and we can see some endoscopy data there, as well as data on clinical remission. So,
I mean, that's good data. Over 50% of people in clinical remission at week 26. That is better than the agents as monotherapy.
What about Seaview?
Yeah, okay, so you're absolutely right. Seaview did show really good clinical remission through trial design. Perhaps a group of people with less severe disease, but maybe I don't know that, because I don't know what all the I don't know enough about the endoscopic baseline.
Right, and I think, to be honest, James, honestly, what I take away from this study is not the clinical outcomes. It's the safety, because here we are combining 3 or 4 different agents for patients with not terrible Crohn's disease, and it's that safety thing that really matters, I think, in this situation, because of course, other than cost, and that's why I talked about ustekinumab potentially becoming a less expensive drug at some point. Other than cost, the thing that probably prevents us combining drugs is safety, and so I'm quite reassured here to see that the number of patients with SAEs and infections is probably not that dissimilar to that which you would see in
standard.
Right, and serious infections in particular, 2 patients out of the cohort. So more combo trials is what I think.
Yeah, I think so. I think I'm really interested in the concept of using small molecules as boosters to induction, and maybe biologics with a more favorable safety profile as maintenance agents, with the opportunity to reintroduce a small molecule without the risk of immunogenicity for flare. And I think we're going to see trials like that coming through, but probably not for 4 or 5 years.
Yeah, I'm not sure I'd use the same buckets you've used there, but I agree. I'm not sure I would lump all small molecules in the same bucket.
No, maybe not.
Yeah, maybe S1p is not.
I wasn't. Yeah. I was deliberately not mentioning names.
No, indeed. I certainly think JAK inhibition, which appears to be, something that's good for induction. The converse, of course, of combination therapy is decreasing combination therapy, going back to monotherapy, and that's why this I think was a fantastic study which Edouard Louis has basically created over many years with large European funding behind it. And this, of course, is following on from STORY, the trial in which patients on combinations of infliximab and azathioprine in an open label study withdrew infliximab. We saw about half of them relapse in 2 years, and over 7 years, about 70% of them relapsed. So there was no control arm there. But this is SPARE, which is a similar study in which there was a control arm. In fact, there were 3 arms in SPARE. Patients on combo therapy, stable combo therapy with infliximab and azathioprine, were randomized either to continue both drugs, to stop azathioprine, or to stop infliximab. The co-primary endpoints being relapse over time, but also the mean amount of time spent in remission over 2 years, because the other part of the study wasn't just stopping, it was restarting if you relapsed. And of course, in fact, what Edouard, I think, really quite cleverly looked at was the whole amount of time you spent being well following a strategy of stopping and restarting. That's a really clinically savvy study.
Yeah, because of course, from a safety and from a cost perspective, minimizing the burden of drug is no bad thing.
Right. So several of us, we took part in this study, and I thought, well, it's going to be obvious what the results will be here. If you stop infliximab, you'll do worst. If you stop azathioprine, you'll do middle, and if you carry on both, you'll do best. But I was wrong. In fact, if you stop infliximab, you do worse. But if you stop azathioprine, actually you seem to do just as well as if you carry on with combination of both drugs.
Yeah, but of course this was a population in whom had been stable on azathioprine for some time, and so you've probably removed the antibody formers from this population.
Right, and I think that's the explanation for this. But of course, the other thing that is really interesting is that when you restart drug, in fact, whichever strategy you use, you actually seem to do pretty well.
Yeah, I was really impressed by this, and I haven't quite found an explanation. So as you quite rightly say, those patients who stopped infliximab, had a flare, restarted infliximab, having remained on azathioprine during the drug holiday, really almost all recaptured response, and that just isn't my clinical experience.
Well, when do you stop the azathioprine? I mean, is it what we're saying that, you know, this is a group of patients who have when do you stop the infliximab?
Yeah.
Is this a group of patients who we've weeded out already the people who are going to form antibodies, so in fact you can stop and restart without concern?
So maybe, yeah, they're all a bit longer on, but reassuring data.
Yeah, really reassuring data. I guess the only problem I have with this study is I'm not sure it's relevant anymore.
What, now that anti-TNF isn't that expensive?
Right, I know.
Yeah.
Why would you stop infliximab? But yeah, I think that's part of the trouble with this.
Let's just see if there are any questions.
Yeah,
and then we'll move on to the last section.
Okay, there's a long question. Once early access starts for UPA, will it be approved via BlueTech for post-pubertal under 16s? I think the answer to that is yes. I think, isn't there an NHS England thing that allows you, once you're post-pubertal, to have access to the same drugs?
I don't know the answer to that. I know that the clinical trial included 16 and above, but I can't answer the...
Oh, good point. Very good point. As it did for risankizumab. Yeah. So who knows? But yeah, I think access will probably get easier. Question here. With all these treatments, novel treatments, where does azathioprine stand in the management of small bowel Crohn's disease? Is it still a drug of first choice? Excuse me. For maintenance in patients with non-fistulizing, non-stricturing small bowel Crohn's. Do we use it anymore as a monotherapy?
I use azathioprine monotherapy less and less. So I post-operative, I do have some people on azathioprine post-operative as a primary prophylaxis, and then rescope them and see whether they've got disease recurrence. There will be people in whom I use azathioprine monotherapy, people with mild disease. I marginally prefer methotrexate as a monotherapy conventional immunomodulator than azathioprine in Crohn's disease. I think, as you said, the drop in price of the anti-TNFs have meant that, you know, you can't argue that azathioprine is either more effective or safer than an anti-TNF, and given that they're no longer that much more expensive, I think the argument is becoming somewhat moot.
I can't remember when I last prescribed azathioprine monotherapy, is the truth. I'm using it very little, just because it's easy to use biologics, and the reality is that that the early side effect profile, the early tolerance profile of azathioprine is less good. So it's not that I don't think it's an effective drug. I just think it relates to tolerance.
So I think we're going to do a little bit on drug level monitoring, and then I think we'll skip to ultrasound.
Oh, do you? Okay.
Yeah, I think we will skip the post-op.
Okay, fair enough. That's because all of those abstracts are mine, and you're having an easy time. Okay, so drug level monitoring. We didn't talk about this so much in the earlier webinars, but one of the studies that was presented was this one. That's NORDRUM-B. This is from the same group of investigators that did NOR-SWITCH. In other words, a bunch of Norwegians, and just like in NOR-SWITCH, they did it cross-image. So they took people with a variety of different immune-mediated conditions, and they randomized them to receive their infliximab either with proactive drug monitoring or by standard of care. Now, you'll notice the abstract is entitled NORDRUM-B. That's because there was NORDRUM-A. Both of these have been published, I think, in JAMA. One of them last about 12 months ago, one of them about 6 months ago. NORDRUM-A was the induction study, and this showed that there was no particular benefit of using proactive drug monitoring with their schedule, it has to be said, in induction with infliximab. NORDRUM-B was about maintenance. So this is people who'd already been on infliximab for a minimum of, and I can't quite remember, I think it was something like 24 weeks, maybe a little bit longer, doing well. And then it was about looking at drug monitoring going forwards from them compared with standard of care. And you can see on the top right hand side of the slide here the therapeutic drug monitoring strategy that they used, which won't be which won't be unfamiliar to any of you that use TDM with infliximab. Sort of drug levels that we are probably fairly familiar with, and basically the drug levels are low, you gave more drug, and the drug levels were high, you could give less drug unless they're very high, in which case you were forced to. So a fairly standard standard type approach. What's interesting is that unlike many other studies in the past, such as Taylorix and Taxid, this did actually show a benefit in that proactive therapeutic drug monitoring strategy. If you look at that sort of survival curve, it's an upside down survival curve at the bottom there, what it's showing is your chance of losing response over time, chance of disease worsening. And it's quite interesting because the therapeutic drug monitoring, the proactive drug monitoring line, actually does really quite a lot better than standard monitoring.
Why is this the positive trial and the previous two weren't positive?
Because of the way they were designed and because of the algorithms used. And the fact is that if you have an algorithm that gives lots of infliximab, you're probably going to do all right.
Yeah, so I guess this is a bit more like standard clinical practice.
It is.
Whereas both the Taylorix and the Taxid study, even the non-proactive drug monitoring did get quite good drug levels.
And I mean, particularly in Taxid, if you remember, actually they standardized everyone right at the start. Basically, they filled them all up with infliximab. to make sure that they had therapeutic levels at the start, and then they monitored them quite closely. And some of the secondary outcomes, there was a hint.
So we think that therapeutic drug monitoring is effective, but we've always thought that realistically.
Yeah, I guess it's just not really been shown, has it? And that's what this showed. One of the criticisms is that when you look at the subgroup analysis, benefit was seen in UC, but not for Crohn's disease. It wasn't powered to show those differences, and I personally would ignore that. This is a slightly different way of doing proactive monitoring. We talked about this before. This is the whole dashboard thing. And this is this time, as opposed to a Dutch study, this is one of the American studies. And this is a retrospective study looking at proactive versus reactive monitoring. Again, it's showing a benefit of proactive monitoring over reactive monitoring. So it's definitely an order of magnitude lower in terms of the quality of evidence than the abstract that we've just looked at. But in this study, they also looked at this sort of proactive arm as well. So this is using a dashboard in which you put in things like drug level, but you put in CRP, you put in albumin, you put in something probably to do with either BMI or weight. I can't quite remember. And I think the point we're trying to make here is that just measuring a drug level might not be the be all and the end all with therapeutic drug monitoring. It might be much more complicated than that. And this and several other abstracts over the years have suggested that, in fact, we need to be thinking probably at a more advanced level. We're very simplistic with therapeutic drug monitoring.
Yeah, so I guess this is looking to see many aspects of a patient's phenotype that might impact the pharmacokinetics of the drug in order to try and get a better area under the curve.
Right, and it might not even be just area under the curve. It might be about peak concentration as well.
So that's always been one of those things that I think is relevant, of course, is that now that we're all using subcutaneous infliximab, we're all seeing that our patients on subcutaneous infliximab have higher drug levels than they did when they were on intravenous. But of course, the reason for that is that we're not measuring a trough level, we're measuring a steady state level.
Right.
And we don't see necessarily a greater benefit of subcutaneous than intravenous. So there may be a benefit of that peak as well as maintaining an adequate trough.
Right, and I think it's important for us to recognise that we don't necessarily understand all this, and I think I think therapeutic drug monitoring is a double-edged sword, and one can overread drug levels. I'm not going to labour this point too much longer, but this is another abstract that really talks about what are we looking at when it comes to therapeutic drug monitoring, and this is actually looking at drug clearance as opposed to drug levels, and it suggests that if you've got low clearance of your drug at the start of treatment, then you're probably going to do better than if you've got high clearance of the drug at the start, which again, you could say it's sort of it's stating the obvious, but it's not necessarily. And I think the PK experts and there are some PK experts on this are really starting to think more about clearance actually than about drug level.
And that's clearance separate from disease activity.
Well,
because of course disease activity influences clearance, and we're back to the people with bad disease do badly.
Very difficult, and the honest truth is, James, I don't know the answer to that question, but that will undoubtedly come into it as well.
And then moving on just a little bit, the only abstract that was not about anti-TNFs in terms of drug levels was ustekinumab, and this is two abstracts, one prospective, one retrospective, looking to see whether ustekinumab trough levels predicted outcome. And you can see on the left-hand side that it does look that a particular trough level, for what it's worth, 5.45 here, was able to predict steroid-free deep remission, which was defined as a clinical remission in terms of patient-reported outcome off steroids with a normal CRP or fecal calprotectin, using a slightly different assay. The retrospective study on the right showed a similar fact, that those patients who achieved a specific level were more likely to achieve a better outcome. And that, I guess, fits with our understanding of the data from both Stardust and Seaview that there is an exposure response curve to ustekinumab. Now, why are we not using ustekinumab drug levels? Because we don't measure them. Do you measure them, Peter?
Intermittently, yes. Not in the same way as we do for anti-TNF. I mean, the key for anti-TNF is as a class, it's more immunogenic, isn't it? And so I think you know, one of the easy things about drug levels is anti-drug antibodies, and we just don't really see those with P40 inhibitors
or
vedolizumab. Whether we'll see them with P19s or not remains to be seen.
Yeah, and of course, I mean, that's one of the factors that came out here, which is that there was no difference in drug levels between patients on monotherapy, those on combination therapy. And of course, that's completely different from the data with anti-TNF, where those on combo therapy have high levels. And of course, the other reason I suspect is that most of our patients on ustekinumab are already on 8 weekly, and many of us will find it difficult to escalate the dose beyond 8 weekly, even if they do have low drug levels.
Right. And at least for the moment, that may change. It may change. Couple of questions, if we may. Is that allowed? Mm-hmm. Yeah, I'm getting the nod. So when stopping anti-TNF, do you keep patients on azathioprine?
100% definitely yes. And the reason for that is that one of the factors that came out of the SPARE trial was that the dose of or not the dose, the drug level of azathioprine was a predictor for recapture of response on restarting infliximab. And so I think if you're going to go through a policy of stopping and starting an anti-TNF, you really have to keep that patient on the immune modulator in the interval.
The other thing here for me is that, of course, azathioprine does work. Yeah. And what I wouldn't want to stop 2 drugs at once. I'd stop one or the other. Okay. How long can you use Imran for maintenance, and how many years would you wait before stopping it if they've got quiescent disease?
It's a great question.
It applies to Crohn's in the question, but you can.
Yeah, well, I mean, it's a great question. So there is actually a stopping trial. There's several stopping trials for azathioprine, predominantly in ulcerative colitis, and one in ulcerative colitis by Barney Hawthorne, the rest in Crohn's disease. And it does show that people who've been on azathioprine for up to 5 or 6 years, those who stop it do worse than those who continue it. Now, of course, you have selected a group of people who've responded, a group of people who haven't had side effects, because by definition, they've been on the drug for 5 years. So it's a bit like the story with 5-SAs. I mean, I don't tend to stop azathioprine in a patient who's well on it until a point at which I am worried about side effects, and so that is coming upwards of about age 55.
Interesting. Yeah. I maybe think about it sooner than then, actually.
Sooner than 55.
Yeah, I do. If I was taking azathioprine and I had a chance to stop it and I'd been well for 5 years, I'd think about stopping it, because I could always start something else. We're just not in the same place that we were, are we? And then another really good and important question, and SPARE it has driven this question, I expect, and it relates to stopping azathioprine on methotrexate. So when you're initiating biologics, do you routinely start combo therapy?
Yes, well, with
anti-TNF. Yeah, okay. Routinely.
Pretty much routinely. There's a slight caveat to that, which is that I don't yet have a feeling for patients who are going to go for IV induction and subcutaneous maintenance. Right. I don't yet have a feeling whether subcutaneous maintenance infliximab is as immunogenic as IV maintenance infliximab. So I don't have that feeling. And there are some people on adalimumab who have not previously developed anti-drug antibodies with infliximab, for whom, for various reasons, comorbidity, for example, I don't want to use azathioprine, which I will start monotherapy.
Yeah, I am a little bit more lax with adalimumab than I used to be, is the honest truth. And it's partly, again, about you've got more escape routes now than you used to have. But if someone's got fistulizing disease, you know, I just want anti-TNF to keep working. And then the second part of the question here, and this is a really good question, is if you do start combo therapy, when do you stop the azathioprine?
Yeah, so I'm more and more happy, and more because we're less facing the pressure, or I feel we're less facing the pressure to stop the anti-TNF. In a patient in whom I think we're going to continue the anti-TNF, maybe they've got poor prognosis disease, I think the data is pointing to the fact that if you've got stable drug levels after about 6 to 8 months of treatment, you don't disadvantage patients by stopping the anti-TNF, so stopping the immunomodulator.
Yeah, I do.
Depends on it.
I mean, I wouldn't. You can't use spare for that.
No.
Because that's not 6 months stopping.
No.
And in fact, if you go back to the original IMID study, it would suggest that drug levels were worse in people at 6 months. So if I'm going to do it, I tend to push out a bit longer personally. But I think drug level monitoring there is really helpful. So, yes.
This is the final section. We've got about 5-10 minutes left to run. The first couple are about, well, the whole section is on new targets. And it's really just to get to the fact that obviously over time, the targets we're aiming for have been becoming more and more robust. Really important message is the distinction between optimizing therapy to achieve a better target versus switching therapy. And I would always draw this distinction. I am more than happy to optimize a partially effective therapy by increasing the dose, adding a different drug, modifying a diet, stopping smoking. And I think that is absolutely excellent optimization. Switching a therapy, you have to be very careful that you don't switch a 70% effective therapy to a 15% effective therapy. So when we talk about trying to achieve harder endpoints and optimizing, we're talking about optimizing partially effective therapies or defining people as non-responders. So this effectively is the target IBD study looking at the role of histological inflammation on an index biopsy associated with risk of loss of response to advanced therapy. And so effectively it was taking a cohort of patients who'd had a colonoscopy, went on an advanced therapy, and what it tells us is that the presence of ongoing histological inflammation is associated with an increased risk of relapse. Now that is data that we've seen in a variety of different formats over time. But again, I come back to the fact that this, to my mind, the presence of ongoing histological inflammation may be a signal for optimizing therapy in some way, not necessarily for switching therapy.
Combo.
Adding in another drug. So, and the final one here, that was in UC, no, that was in both diseases. This is looking at transmural healing. And this is a newish concept. We've been very used to looking for endoscopic healing of ulcers, and this is combining endoscopic healing with normalization of MRI findings. So looking to check not just at the mucosa, but have you healed the bowel wall thickness, the edema, the enhancement. And what you see in this study is that patients who have achieved both endoscopic and MRI remission do much better than those who have simply achieved endoscopic remission, and obviously they do better than those patients who haven't done either. And this is looking at outcomes like steroids, hospitalization, or surgery. So I guess like everything, it's a combination. But again, I come back to this is optimization versus switching.
So you mentioned MRI there, and you know the reality is that MRI is fantastic as a way of looking at patients with inflammatory bowel disease, at least patients with Crohn's disease, but it's expensive.
We have a huge wait for MRI.
Do you?
Yeah.
Oh, we don't.
No.
But there are, of course, other ways of imaging the gut, aren't there? And ultrasound is one of those. And, you know, I think over the years, the number of ultrasound abstracts in DDW has increased.
Really increased, yeah.
And I think when they first started coming out, I used to think, oh, another ultrasound abstract. And now, of course, I think, ultrasound, the way forward in life. And the reality is that I think in the UK, we've been way behind the curve here. Ultrasound is clearly a good way of looking at patients with Crohn's disease, and there were a few abstracts here. There's 4 different abstracts presented here. I don't think there's any great benefit in going through all of these abstracts, but it's useful in terms of a variety of things, in detecting active disease and perhaps detecting, one of the advantages of ultrasound, of course, you can actually see what's happening. You can see the bowel contracting. You can see.
So looking at motility, very good.
Right.
Predicting post-operative recurrence there,
right.
Good.
Yeah.
So my eyes were open when we had a consultant colleague visiting from abroad who spent some time with us and did ultrasound in our clinic. Literally, as we were seeing patients, she would do an ultrasound, and it really does change stuff. It's a really useful addition. So I think my eyes have been slightly open to this.
And one of our fellows just looked at a month's worth of patients who were having colonoscopies for investigation of either known IBD or suspected IBD, and indeed MRIs, and looked at what proportion of those could be done by ultrasound instead, and then working out the cost savings. There's a very clear cost argument here as well as patient benefit, and it doesn't just apply to Crohn's disease, it applies to ulcerative colitis as well. And that one of the things that we keep preaching about is this: you've got to reassess your patient, and ideally, and I say we, I mean this is what's said in inflammatory bowel disease, you want to start your patient on the drug, and ideally with ulcerative colitis, you then want to go and scope them like somewhere around week 14 to see what's happening. Well, these data suggest you don't need to do that.
No,
you can do it with ultrasound. Yeah. And that's kind of more realistic. And that, unlike when you send someone for an MRI where they see a radiologist, and in fact they probably don't see a radiologist, they see a radiographer. When you put an ultrasound probe on, if we learn to do it, you see a gastroenterologist and you can make your decision there and then. I think that's what's most exciting about this, and what's probably realistic about using ultrasound in everyday practice.
And so I'm going to finish now with just the last, which is, I guess, looking to the future, and that's artificial intelligence. And there are 3 abstracts on this. One is looking at a machine learning algorithm that took histological slides and used an algorithm to assess the ulcerative colitis activity, and compared that to 3 different histopathologists. And what it showed is that a machine learning algorithm can be as effective using an intra-class correlation coefficient in terms of the ability to predict disease activity than the histopathologists. The same sort of concept coming and reading CT enterography. This was a retrospective study looking again at a machine learning model showing really very good agreement between a machine learning algorithm and radiologists at predicting disease severity. And the final was endoscopy. This is again a machine learning algorithm looking to see whether an assessment of endoscopic disease activity throughout the length of the colon in ulcerative colitis was able to predict mucosal healing better than central readers, and it definitely could. And its ability to be able to demonstrate gradations of disease severity showed that using these kind of artificial intelligence algorithms, you may be able to reduce the sample size required to show benefit of drug over placebo. Now, none of these are available in current clinical practice, but I guess, 5 years ago we were thinking, is ultrasound really going to be really a point of care test? I think it probably, we agree now it will be, and we just need to get the UK colleagues trained up. I think artificial intelligence will play more and more of a role in our clinical practice.
Yeah, and that's going to mess up your private practice, isn't it?
So I think we're going to finish here. Pete will just look to see if there are any last questions.
There is one last question. Is there a benefit in using ultrasound in UC over and above fecal calprotectin?
Oh, that is a good question to which I don't know the answer. Do you know the answer?
Yeah, I think there probably is some benefit in that it's probably more reliable as a cross-sectional test rather than as a longitudinal test, I think fecal calprotectin is quite good in a longitudinal way. It's less good in a cross-sectional way. And I think when you look at bowel wall thickness with ultrasound, then that's possibly slightly better.
Thank you very much indeed to Debbie and the whole team at CornerStones. Most importantly, thank you very much to our very generous sponsors. Thanks to you for spending the evening with us, and Pete and I will say good night.
Bye-bye.